Most of them are non-functioning, okay. So here we use this one phrase here, esthesiometer, for light touch. Some hair-like projections are supposed to be present here, which is missing. That's why you use the cotton for fine touch, okay. Fine touch is you apply a very low threshold, and that is going to be perceived by your skin, your superficial structure. And deep sensation is going to be perceived by your structure underneath the skin, your muscles, your tendons, your bones, your joints, etc. Okay. Now there is visceral sensation. What is visceral sensation? Of course, the examination of which cannot be done. Sensations, suppose, you know, whenever you see a patient suffering from heart attack or cardiac failure, the patient usually complains of, can you say, what the patient will initially complain of? Chest tightness, chest pain, suffocation, and the pain always referring to your left shoulder and left hand. You'll always have to think that the person is supposed to is an heart attack is, you have to presume and you have to immediately rush the patient to the hospital and then do the ECG, Chopty test and whatever. Then if there is any kidney stone, suffering from any kidney stone, the patient complains of retroperitoneal pain. Kidney is a retroperitoneal organ. Okay, so these are the visceral sensations that are perceived by your visceral organs. And then there are, of course, spatial sensations, you know, the vision perceived by your occipital area, hearing, temporal area, then taste, smell, olfactory area. Okay, so these are the general sensation. Now there is tactile localization. Okay, peripheral sensations are those that are touch, pain, temperature. These are the peripheral sensation, and cortical sensation, we will discuss them. Tactile localization, 2-point discrimination, okay, vibration, stereognosis, these are the cortical sensation. Now what is tactile localization? When a subject is sitting in front of you or your patient is sitting in front of you, you apply certain things on the certain parts of your body, and we always do it from dermatome to dermatome. If you are checking the C6 of one hand, simultaneously you will have to check the C6 of the other hand, and then you will ask the patient to localize the area. Suppose if I am touching a pen over here and the subject's eyes is supposed to remain closed, okay, you will ask the subject that where you are feeling the sensation. The subject will show either here or here, whatever. So you can understand that her ability to perceive tactile localization is intact. Okay, all these things will be disturbed in any sensory dysfunction, or you know, the touch, pain, crude touch is perceived, it travels by the ascending tract, pain, temperature by the lateral spinothalamic tract, and vibrations, stereognosis. Okay, then tactile localization, 2-point discrimination, they travel by your posterior column. What is 2-point discrimination? What is 2-point discrimination? We use a compass. Compass was not here. We call it Weber's compass. Okay, now compass, when you are using a compass, how many points are actually present in a compass? 2 points. So whenever somebody is placing a compass on your hand, on your arm, so initially you will feel, you know, that the sensation you will feel at 2 positions, but gradually you are supposed to diminish the gap of the compass. And then when you completely reduce the size of the compass and you completely close the compass, okay, at one particular point, irrespective of having 2 points in your fingertips, mainly in your fingertips, there are numerous cutaneous receptors present in your fingertips which are extremely sensitive to this touch sensation. So they are able to perceive these 2 points till you know, when the compass is, you are measuring it, till the time you completely close the compass, your cutaneous receptor present in your fingertips will be able to perceive the sensation. Then when you completely close and diminish the gap at one particular point, you will feel one sensation. It will be, and you will measure the distance with a scale. You see in the fingertips, it's approximately 2 to 3 millimeter. Then when you same thing you apply on your back, you will see at a distance of 7 centimeter, that is when the compass is actually open, you are able to feel one sensation. Because the sensitivity of the receptor present in your back is less, and the receptor also present at the tip of your fingers is very less compared to the present in your back. So this is 2-point discrimination. Okay, so we have discussed tactile localization, tactile sensation, and 2-point discrimination. Now what is the applied aspect here? What is the applied aspect in case of tactile sensation? What is loss of sensation known as? When you are going to operate on someone, anesthesia, okay, complete loss of sensation with complete loss of consciousness is known as general anesthesia. And if local, and there is another thing, if there is complete loss of consciousness, we call it general anesthesia. If there is loss of consciousness is not there, local anesthesia and spinal anesthesia. Lower part of the body, you okay. So what is happening in, can you name a general anesthetic drug that is commonly used these days? It is used in spinal anesthesia and local anesthetic drug, sodium channel blocker. Okay, general anesthesia. Like when you are sending the patient, you are introducing coma into a patient. You know, you are introducing ventilation into the patient. You are completely anesthetizing. There is complete loss of consciousness. The patient for the timing is completely, the respiratory function is dependent on the ventilatory system. And then you will have to bring, it is propofol. The most commonly used general anesthetic drug these days is a propofol. Okay, it is a cation deloader. Okay, now for the sensation, now listen one thing. If I want to move my thumb, what is happening? You have studied action potential. Upper motor neuron present in your central nervous system or present in your motor area that is controlling the thumb, fired down, stimulate the lower motor neuron, and you move your thumb. So there is a particular area in the central nervous system which is firing, and there are particular and effective area in your central nervous system which is preventing the unwanted or the undue spread of the electrical current to the other part of the neuronal circuit. If you want to move your thumb, you are only moving your thumb. Means the spread of the electrical current to the part that is going to move your arm or your legs or other body is prevented. There, your central nervous system is equipped in a way that if you want to stimulate a particular area, it is going to trigger that particular area, and there are effective mechanisms that is going to prevent the undue spread of the electrical current to other part of the neuronal circuit. A recent data suggested that if you are supposed to make a computer, depending upon the number of the neuronal circuit present in a human brain, it will be equivalent to the size of England. Okay, but my point is that if, you know, I want to move my thumb or I want to move my arm, a particular area in your central nervous system is firing. But then, and it is triggering down, sending the action potential, and you are able to move that particular area you want to. So there are equally effective mechanisms that is preventing the undue spread of the electrical current to the other parts. What is an inhibitory neurotransmitter? You must remember what is the main inhibitory neurotransmitter present in your upper nervous system. Can you say the stimulatory and the inhibitory neurotransmitter? Stimulatory, write it down, it's cholinergic, glutaminergic and aspartate. These are your stimulatory neurotransmitter. Cholinergic, glutaminergic and aspartate. And what is your main inhibitory neurotransmitter? Yes. Gamma aminobutyric acid. You know, in spinal cord, glycine is also involved, but in the upper nervous system, it's mainly GABA, GABAergic system, gamma aminobutyric acid, which prevents the undue spread of the electrical current to the other parts of the neuronal circuit. Abnormal electrical discharge in the central nervous system. It's a very interesting subject topic you will read in medicine. Abnormal electrical discharge in central nervous system is epilepsy. Okay, when you are either there is over functioning of the stimulatory system or mainly there is under functioning of the GABAergic system. So complete loss of sensation is known as anesthesia. The general anesthetic drug, safest anesthetic drug commonly used most in these days is propofol, PROPOFOL, which is a cation deloader. And like your friend said, spinal anesthesia and local anesthesia we use lignocaine, procaine. Okay, these are the local anesthetic drug, and used in spinal anesthesia they are again sodium deloader. You know now what is this deloading, what is happening, how an action potential is generated, what is happening in the neuron? Sodium influx, potassium efflux. So again there are the calcium, sodium and calcium. When there is unsuppressed entry of the sodium and the calcium, what is happening? Your neuron is becoming depolarized. It is becoming easy to bring the resting membrane potential to the threshold potential and then generate action potential. So most of the, you have to remember, in most of the, even in, you know, severe anxiety disorder, when the patient says, there are cases we say paraesthesia, the patient will come to you and the patient will complain burning sensation, severe burning sensation from below the neck to your, you know, both the legs, psychosomatic disorder. These are also abnormal, you know, these are because of the excessive action of the stimulatory system and the under functioning of the inhibitory system, mainly the GABAergic system. So in all the epilepsy or whatever this focus and whatever this abnormal sensation, our main point of focus is to increase the activity of your GABAergic system. and to decrease the activity of this, sodium influx, calcium influx. Okay, because when a neuron, if you make the neuron hyperpolarized, in most of these drugs, what happens? Potassium efflux is occurring. If potassium comes out of the neuron, your neuron is becoming depolarized or hyperpolarized. When potassium is coming out of the neuron is becoming depolarized or hyperpolarized. Hyperpolarized, it is becoming more electronegative. So if the resting membrane potential initially it was minus 90 millivolt, it will, suppose you take it down to with continuous efflux of the potassium, and sodium and calcium are not allowed to entry, and chloride ions are going in, so it becomes very much electronegative. Suppose it reaches 100 minus 110 millivolt, then it becomes very difficult to take this to the threshold potential and then generate action potential. So this electrical firing remains inhibited. This is the most of the mechanism of the drug used in all this abnormal electrical activity in your central nervous system. Either they are cation deloader, or they increases the influx of the anion, or they increases the efflux of the potassium from the neuron. Okay, so and partial loss of sensation is known as hypoesthesia. Can you say a condition? So whenever you are doing this sensation, tactile localization, you are doing it on both the, you simultaneously check it on both the sides. So when there is partial loss of sensation, suppose in one hand you are feeling, you can feel the sensation, and the other hand there is diminished sensation, what do you say? That is hypoesthesia. It can occur, suppose you are sleeping on one hand, resting on one hand, suddenly you feel the numbness, you are not, exactly, okay, suddenly you feel numbness on your hand, or if there is hemiplegia, loss of paralysis of one side of the body occurs in cerebrovascular accident. Paralysis of one side of the body is known as hemiplegia. Paralysis from the neck to below downward, all the part of your body is known as quadriplegia or tetraplegia, and the paralysis of the lower portion of your body is known as paraplegia. Okay, so these occur in cerebrovascular accident, commonly stroke. Other than the medication, the therapy that is you prescribe to the patient is physiotherapy, so that you can activate the muscle and all these things. So loss of the sensation on one side of the body is hemiplegia, and all over the body, entire body is tetraplegia. So you can include this in hypoesthesia. And then there is hyperesthesia. If somebody is touching you, a normal touch, you feel that somebody has grabbed your exaggerated sensation is known as hyperesthesia. It again occurs, in the lateral column lesions and all these things. Okay, so we have discussed tactile sensation, tactile localization, 2-point discrimination. Now comes pain sensation. Again, it is categorized into superficial pain and deep pain. Superficial pain, there are pins present over here. You touch somebody like this. Okay, you don't injure the patient, just a small prick or something, that is just going to be perceived on your superficial, your cutaneous structure, that is superficial pain. And again, if you pinch someone, you are involving the muscle, you are pressing it, so that is deep pain. When again you are involving the muscle, your bone, there is bone fracture, you feel, okay, so that is deep pain sensation. Now, loss of pain sensation is known as analgesia. Okay, you must remember there is a difference between loss of touch sensation or loss of normal sensation and loss of pain sensation. Loss of sensation with loss of pain sensation, of course, if you are not able to feel anything, you won't feel the pain stimulus. That is anesthesia. And loss of pain sensation is known as analgesia. If you are having, can you name one analgesic drug? Very commonly used analgesic drug, you all know that. Paracetamol 650. Paracetamol, the most commonly used, it is an analgesic, antipyretic and anti-inflammatory. Analgesia means analgesic itself, it will cause loss of pain. Suppose if somebody complains of a nagging headache, we say that, take one paracetamol 650. What is pyrexia? Paracetamol is antipyretic. What is high fever, high temperature is known as pyrexia. So paracetamol is also antipyretic and anti-inflammatory drug. Then again we use morphine, opioid, narcotic, it is also a painkiller. Usually before, morphine was very much used as a painkiller drug, but now it is not used that much. Then again ibuprofen, okay, these belong to the non-steroidal anti-inflammatory class of drug. So analgesia is loss of pain sensation. Then there is again hypoalgesia, partial loss of pain sensation. Hypoalgesia, partial loss of pain sensation. Physiologically, there is a term known as exercise-induced hypoalgesia. When somebody is vigorously, doing exercise, there is diminished sensitivity to the pain stimulus during and sometimes afterward the exercise. So this is known as exercise induced hypoalgesia. Okay, then again in peripheral neuropathy. Peripheral neuropathy, in most cases, diabetes is a very common cause of peripheral neuropathy. The patient complains of numbness and tingling sensation in the peripheral extremities. Okay, so if a particular area of your finger is gone numb, you won't feel any kind of sensation in that area. So that is again hypoalgesia. And now say, what is exaggerated pain sensation? A touch sensation or any kind of stimulus that is not supposed to elicit any kind of pain will cause an exaggerated amount of pain. That is known as hyperalgesia. It occurs in posterior column lesion. It also occurs in tabes dorsalis. It is a sexually transmitted disease caused by the bacteria Treponema pallidum seen in patients suffering from syphilis. Then there is another condition known as allodynia. There is another condition known as allodynia. Allodynia is also increased sensitivity to pain sensation. Any kind of stimulus that is not supposed to evoke or generate pain sensation will cause tremendous amount of pain. It occurs in posterior column lesion, in demyelinating disease of the central nervous system, fibromyalgia. Do you know what is fibromyalgia? Excessive muscle pain and muscle tenderness is known as fibromyalgia. Okay, so allodynia is also a condition in which there is excessive, stimulus to pain sensation. So we have discussed diminished loss of pain sensation is known as analgesia, partial loss of pain sensation is known as hypoalgesia, and exaggerated pain sensation is known as hyperalgesia. Okay, now we come to vibration. Again, it is a cortical sensation. You see the tuning fork, you strike it on a bony prominence. You're not striking it on someone's head. You will strike it on a bony prominence and then you will place it on the subject's hand. You have to ask two things. First, you will ask the subject to say whether you are able to feel the vibration or not, and then you will ask the subject that to report you when she or he is unable to feel the vibration sense anymore. Okay, and when the patient says or the subject says that he or she is not able to feel the vibration anymore, you are supposed to keep it on your hand and check it with your, so that you can see that whether there is any difference or it is normal in both the subject and the patient. Again, vibration sensation will be diminished in posterior column lesion. It is carried by the sensation is carried by the posterior tract. Okay, in tabes dorsalis, in posterior column lesion, in peripheral neuropathy, there is diminished vibration sensation. Then temperature, we don't have the apparatus here. You take two test tubes. On one test tube, you place hot water. Of course, not hot enough to injure the skin of the patient, but moderate hot or warm water. And in another test tube, you take cold water and then you place it on the subject's hand. Of course, the hot sensation will be received as hot and the cold sensation will be received as cold. This is how we take the temperature sensation. Now there is known as stereognosis. Stereognosis, S-T-E-R-E-O-G-N-O-S-I-S. Stereognosis, ability of the subject to perceive the size, shape and form of the object with the eyes closed. If she is sitting in front of you with her eyes closed, you give certain objects in her hand. Okay, you give this marker or you give the duster and you give certain coins or you give the pen and you ask her to, what is it? If it's a duster, of course, with closed hand, she will feel it and she will say a duster. If it's a scale, she will touch it and she will say a scale. Sometimes we give coins of two different sizes on both hands and we ask which one is the larger and which one is the smaller. So the ability to perceive the size, shape and form of the object is known as stereognosis. It is again, in parietal lobe lesion, this ability to perceive this size, shape and form of the object is ruined. You are not able to, determine the difference, and the condition is known as stereognosis. Okay, the condition is known as stereognosis and it occurs in parietal lobe lesion. Then there is something called proprioception or determination or sense of position. What you do, you take the hand or the arm of the patient and with the closed eyes, you move it in any direction. You keep it upward and you ask in which direction I am pointing your hand or I am pointing your finger. If it's up, she will say up. If it's down, she will say down. Suppose like this, she will say neutral position. So this is known as determination of position or proprioception. Then again we do one thing, we rotate the arm of the patient for 4 to 5 cycles and then we keep it one direction and then we ask the patient to keep the other arm in the same direction of your right hand. This is known as proprioception, the ability to perceive in which position or in which location or in which direction your arm is placed, okay, or your fingers joint movement. This is again, this will be disturbed in the parietal lobe lesion because it is transferred by the posterior column. And then we come to paraesthesia. What is paraesthesia? I have said this in the beginning of the lecture. What is paraesthesia? Can you say what is paraesthesia? Huh? Paraesthesia jinishta ki abnormal sensation. You know, in psychiatry you will see some patients suffering from severe anxiety disorder or depressive disorder. Listen, any kind of psychiatric disorder, they will come and say that they feel the crawling of the insect on their body. They feel unnecessary tingling sensation all over their body. Okay, they feel burning sensation all over their body, numbness, and sometimes they feel the sensation of becoming very cold. Okay, so this is known as paraesthesia, the feeling of abnormal sensation. Okay, this also occurs in the parietal lobe lesion. This is the Vaughan phrase here, esthesiometer for light touch, but you never use this, you use cotton. So always now there are certain things that you must instruct the patient or instruct the subject. Something, don't worry, in pain sensation I won't prick you or anything, I'll just at a pain. Okay, so first is, of course, you will ask the subject to keep her eyes closed. Okay, then you will instruct the subject. Always in any examination, you have learnt it 1,000 times, whatever examination you are going to perform on your subject, you will always instruct the subject that what you are going to perform. If suddenly you hit a tuning fork and you know, if the subject, mostly in all these cases, neurological patients come to you, suffering from any kind of psychiatric disorder or any mental stress. Of course, if there is certain sensation, if somebody is having psychosomatic burning sensation, it's a very painful, you know, some patients we have seen complaining, they are literally crying, that they feel that somebody, you know, the entire body is like on fire. So of course, you do certain experiment, you'll scare the patient, you'll scare the patient more. So 5 things that you must remember is the subject's eyes should be closed. You are always going to instruct the subject, whatever experiment that you are going to perform on the subject, and then you always go it from distally. You start it from distal and then you ascend. Okay, because any pathology, it affects your distal proximity first and then proximal. And you check it from dermatome. If you check C6 on this side, you are supposed to check the C6 of other side, then C8. Okay, so you check it dermatome to dermatome. And then what you do? You always check it on both sides and you ask the patient or ask the subject that the sensation that you are feeling, is the intensity of the sensation similar on both sides or not. Okay, now can you place both of your hands like this? Okay, close your eyes and when I will touch you, if you feel the sensation, you just say yes or no. Okay. Say it, okay. Jore bolbi, so that your friends are able to. So you can see her tactile sensation is intact. So this is fine touch. You are applying and you can apply it on the rest of our body, okay. So like this. Now there will be deep sensation. What you do for deep sensation is also known as crude touch or pressure touch or sustained touch. It is carried by the crude touch sensation is carried by the anterior spinothalamic tract. Keep it like. Yes. So this is, you know, this is pressure touch or this is sustained touch. Hey, acha, give me a pen. Okay. Okay, there is the pen. I won't prick her or something for the pain sensation. I won't do it. Okay, I won't do it. Don't worry. Don't worry. Okay. So, okay, so for pain, superficial pain, again you will just say it loudly. You can feel the sensation, say it loudly. Yes. 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 So this is superficial touch, the superficial pain sensation. For deep pain sensation, ekটু চিমটি কাটছি. Okay. So these are the deep sensations. So you do all these things. Okay. Then for the vibration sensation, what you will do? You will. Okay. কিচ্ছু হবে না. You will just feel the vibration. You won't feel any pain. Look. Wait. Keep your hand close. Okay. Can you feel? থেমে গেলে বলবি. ঠিক আছে? Simultaneously, have to check it with yourself. Vibration is diminished in vibration loss, posterior column lesion, okay? Tape's dorsalis, posterior column lesion, neuropathy, diabetes, okay? Peripheral neuropathy, anything that's causing peripheral neuropathy. Now determination, now proprioception. With your eyes closed, I'll move your fingers in certain direction. Can you say whether it's upward, downward? And if I place it like this, you'll say neutral position. Okay, so close your eyes. Upward, down, neutral. Which side is this? Right, right. Okay, see, she is okay. Okay, now you do this. You rotate the hand of the subject for 3 to 4 cycles, and then you place it at certain. Can you place the same your left hand in the direction of your right hand, where your right hand is? Can you position the left hand? Left hand down. বাঁ হাতটাও যেখানে রাইট হ্যান্ডটা আছে কর, চোখটা বন্ধ কর, ওপরে 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 হাতটা। Okay, she is scared. This is proprioception. Okay, so this is so basically it's intact, but she is scared. Okay, so okay, go. So these are the things. There is nothing more to be done. ঠিক আছে? Okay, so learn the abnormality, few abnormal. Okay, the 2-point discrimination I have said, their compass is not here, so I am not able to show it. This 2-point discrimination, one question that is asked to you, what is the function of this 2-point discrimination and where it is used? In Braille's reading, you have to say this. Braille's reading, it is BRAILLE. It is, in a paper, there are raised dots, elevated dots. The blind patient or the patient with very low vision, they perceive it with their fingers and then they read. The alphabets are decorated in that manner that you are able to perceive it with your finger and then you say it. So this is done 2-point discrimination. This is the function of 2-point discrimination. It's used in Braille's reading. Then there are 2 more things, graphesthesia and barognosis. Graphesthesia is the ability to perceive the symbols. Like if your eyes are closed and somebody, like alphabetic order, somebody writes an S, somebody writes an A, somebody writes B, you are able to guess that, by the tracing in the subject's arm or hand. This is known as graphesthesia. And there is something known as barognosis. Barognosis is again the determination of weight of the object by both hands. On one hand, you have given a bottle loaded with water, filled with water, and the other hand, you have given somebody an empty bottle. So, of course, the patient is able to say which bottle is heavier and which bottle is empty. This is the determination of the weight of the object. Okay, so the stereognosis, graphesthesia, barognosis, everything. Abnormal sensation is known as paresthesia. They occur in psychosomatic disorder, mostly in parietal lobe disorder.
So, once again, to go back or retrospect back to the anatomy which is related to the lower limb, which we had covered months before. So, we are covering these particular sessions on this radiology of the lower limb, which includes this particular understanding, this radiological feature. We are going to do this particular radiology of the lower limb, and followed by, in the next session, we are going to identify the radiology of the abdomen and the pelvis. Now, this particular content of the radiology or radiological anatomy, normal anatomy in the gross, and identifying the osteology as well. So, we have gone through this particular radiology session before as well in the different parts of the body, likewise the thorax and the upper limb. The same rule prevails here as well whenever you are decoding this X-ray or skygram in the radiology of the lower limb. Now, the radiology of the lower limb, we are going to focus over here, emphasize on the normal radiology of the osteological parts. So, we have to understand this particular bones which is present on that particular part, and we have to identify how we are going to read these particular bones. So, whenever you are learning these bones in osteology session or in a gross anatomy, we usually focus on the bony features. We identify on the muscle attachments, we identify on the joints. Here, we are going to see this particular content of these particular bones or this particular content of the joint in living structures. So, whenever you are seeing this, you are going to identify the normal thing. That's what we are projecting at the beginning, and later on we are going to identify these diseased or pathological, and how to identify this pathology will be carried through in the higher classes. Now, about this particular radiology of the lower limb, the basic principle of identifying things is the same. So, whenever you are given a skydiagram plate, the basic question to be asked to your mind that what kind of picture we are looking at. It's kind of like a general X-ray or a special X-ray. That's the exercise that you have to do. The general X-ray means you are going to identify the organ which is easily visible by these penetrations of the light thrown to a direction and taking a silhouette or an image which is formed at the back side. So, it's nothing but catching a shadow which is been held here whenever you are doing this particular X-ray. So, that's what we are going to do with the order of these things in the reading an X-ray is that the plane which is normal thing which do not require anything special, that means we call them as plain X-ray off. And if you are seeing something beyond bones, beyond soft tissues, anything which is related to the very intricate soft tissue, nerve, blood vessels or any particular organ itself, if that thing becomes visible, we call them as the spatial. Now, the spatial thing, as you understand, to see that things needs special procedure or special investment, so that you can see that spatially and identify the disease which is present on it. So, in case of this particular radiology or the skydiagram or X-ray of an individual, a spatial thing means you have to put some dyes or do some anything which makes this particular thing visible, like blood vessels or any kind of hollow organs if you are seeing them. Then the next elemental question, after these, whether plane and this contrast or spatial have been decided there, then comes the look on it, how this particular rays are coming front to back or back to front, from the sides, lateral, right lateral, mid or medial, what side it could be coming, we call them as lateral views. Or if it is coming in the diagonal things, like neither it's lateral, neither it is front, we call them as oblique views. So, based on these particular views, you have to see these particular views. Now, next in what you are seeing, that means that particular X-ray plate, the silhouette is catching what kind of parts of the body. If it is upper limb, upper limb. If it is lower limb, lower limb. If it is thorax, thorax. Abdomen, abdomen. Then you have to break it down which part of it, like visible what? It's bones visible, what are the bones? If it is soft tissue you are seeing, what are the soft tissues? If you are seeing a segment of the upper limb, you have to see upper segment of the upper limb. If you are seeing shoulder joint, you have to mention shoulder joint. If you are seeing hip joint, showing this and this. Just like narrating a picture, that's what you are going to do. So, that's the thing about identifying it. Bony tissues, soft tissues, that's what you are going to identify. Now, how are you going to identify this particular bony tissue, the soft tissue? The bony tissue is going to take this ivory stain. That means it looks like white. That means ivory stains. That means tusker teeth. That means it's bone. And soft tissue, it's going to be gray. That means it is neither black, neither white. It has to be in between black and white. We call them as gray. Now, if it is trapped anything which looks black, that means it has maximum penetrability. What penetrates maximum is if it is empty space or if it is having air. If you are looking at this X-ray of the lung, it will be black. That means it is air which is having maximum penetrability. So, that particular shadow is looking like bones or gray tissue which has to be like soft tissue, and if you are seeing something really black, that means it is penetrating this particular X-ray to a fullest extent. That's why it is black. Now, coming to this particular lower limb extremity, radiological understanding is that we mostly identify this lower limb based on these joints. So, we have three major joints to cover, starting with the hip joint, then you move to the knee joint, then you go to this particular foot which includes the ankle joint. So, involving this particular joints, we see this particular bone which is articulating or forming that particular joint. Once you see these particular bones, we have to narrate the bones and as well as the joint that we are looking in and what kind of thing which you are looking, if it is a normal or abnormal. In 100% of the cases in examination, we give you the normal skydiagram. That means we are not interested in learning about this particular disease at this particular point. It is restricted for the higher classes. So, whenever you are given this particular skydiagram, you have to mention this particular lower limb joints involving that, and what joint you are seeing, whether this particular joint is formed by these normal bones or not. So, joint comprehension and joint formation we already have known. So, let us start with this particular joint, which is this particular important part of this particular bone formations in the lower limb involving here is the hip joint. So, this is a diagram of the hip joint that is projected in here. So, whenever you are seeing here the same thing which will be asking yourself in sequentially that what you are seeing exactly is a kind of plain X-ray, or if you are seeing something special. If you is plain, all right, fine, go for plain. If it is a special, then you have to mention it's special. Next part, how we are looking at. You are looking in the front view, lateral front view or lateral views. If it is front view, mention about front view. If it is a lateral view, you have to mention it lateral. If it is oblique view, you have to mention it is oblique view, etc., etc. Plain and simple. So, then you have to figure out what kind of things you are seeing in this particular diagram picture, like the region what you are seeing here. This particular diagram is a broad thing which is taken along with this particular part. Usually, whenever you are focusing in particular X-ray in the hip joint, we usually give a precise X-ray of the hip joint. Here, everything is broad over here, which you are seeing here. Anything beyond X-ray, that what is visible also you have to understand, but we will be emphasizing on the hip joint over this particular region. So, for example, this region we have this particular hip joint which is formed by the bones. So, whenever seeing here, you have to say that the bony shadows whatever you are seeing. So, whatever the bones you are seeing in sequentially you have to identify what is the pattern. Either you can start above down, or you can start from right to left, so that you can just like follow in sequence, you do not miss anything. So, either you have to come down above below, or below above, or right to left or left to right, whichever is easy for you to understand. So, once you identify this particular bony shadows, then we are going to for the gray shadows, which is the soft tissue shadows. If it is visible, if something special is visible out there, you have to mention. If not, then let it go. Then anything beyond that gray shadow and white shadow, that means black shadows, which is largely filled up with airs. If you are seeing anything, that's what you are going to see. So, this particular diagram picture is a view which you are going to see, this anterior posterior view of the hip joint, or hip joint with the pelvis, or hip joint with the pelvis with the bones of these particular vertebrae. So, you have to mention like above, below, what you are seeing bony shadows showing here is this region. So, what are the region is shown here is the thorax region, which is related over here is lower part of the thorax, whole of the abdomen and pelvis, and the hip joint and upper part of this thigh. So, this particular region which is covered by these things, you have to just like mention about it. Then you have to say this showing bony shadows like ribs, then in the midline vertebrae. If you can specify the vertebra, specify it. If not, just vertebrae. Then move down. Then this particular bones, this is right hip bone, left hip bone. In between, if you can figure out the sacrum, mention about the sacrum. If you can mention about this tailbone, which is coccyx, you are seeing here, mention it. If not, let go. Then you have to go down, move down, this particular bone, which is present in here, hip joint formed over here by this particular bone, which is the femur. If whole femur is visible, you say that whole femur. If it is not, part of the femur. Which part of the femur? Upper part or lower part, etc., etc. That's what you have to narrate. Then over here, if you have done with this particular bones, identifying different parts of the bones, then move to this particular joints if you are seeing any. So, this particular region, if you are seeing any joints, you have to mention. Like for example, we are focusing here in the hip joint. So, you have to mention about the hip joint, right side, left side, if it is there. If it is right side, only mention about right side. If it is left side, only left side. That has to be marked L or R depending on which side you are looking at. Then the special joints other than this, so right side hip joint, left side hip joint, anything other than this particular joint, sacroiliac joint. If it is both side visible, mention about both side visibility of these things. Then this particular midline joint. What midline joint we have? All right, amusement park. Anytime you can move in, anytime you can go out. Jingalila. Anyways, so this particular midline joint, which is symphysis pubis. Now, once you just like go through this joint, if you can figure out what kind of joint you are seeing here. It's a synovial joint, or it is a fibrous joint, or any kind of joint like that. Secondary cartilaginous joint, primary cartilaginous joint. That's what you have to ask primarily in your mind, because giving this particular diagram, we might put a pointer over here in this midline and ask about this particular joint. Then we can throw the question based on what kind of joint it is. It is a secondary, primary, or any kind of cartilaginous joint, or it is a synovial joint. Now, then on we can just ask about further questions. So we can go anywhere we want to based on a single pointer. Similar to that, we can identify this particular joint. We can say that this is a sacroiliac joint. Identifying the name of the joint. Then you have to mention what kind of joint it is, synovial, or it's kind of anything else, right? So what kind of joint is the sacroiliac joint? Sacroiliac joint is what kind of joint? Synovial or fibrous or cartilaginous? Now, if I don't see somebody, they cannot see me. And if they don't see me, I don't see them. That's a rule, right? So, what kind of joint it is? But I think it is a cartilaginous joint, because they have a cartilage in there. So, what is the difference between the synovial joint with the cartilaginous joint? Synovial fluid থাকবে, আচ্ছা. What else? So, what kind of cartilage is there in a cartilaginous joint? What are the different types of cartilage? What are the different types of cartilage? How many cartilages are there? How are the different types of কি নাম আছে cartilage গুলো? Hyaline cartilage. Why we call them as hyaline cartilage? Glass-like appearance. That means transparent. What are the other types of cartilage? Elastic cartilage. Where we see elastic cartilage? Give an example where you see that. Here, hold it, pull it. Yeah. So, elastic cartilage. And what are the other types of cartilage we have? Fibrous cartilage. So, what are the difference between the hyaline cartilage and the fibrous cartilage in a cartilaginous joint? What is articular cartilage? What kind of cartilage is articular cartilage? And what is a fibrous cartilage or fibrocartilaginous joint? What is primary cartilaginous joint? What is secondary cartilaginous joint? These are all very difficult questions. Very, very difficult questions. But see there, these are the basic thing why you fail in examination. Not answering the basic questions. We do not ask you anything to tell about rocket science or see how this particular thing is projected in the satellite and tell me the detail of it. We do not ask those things. We ask basic questions, very basics. 10 standard, 12 standard questions to start with. Then we go into it. And you fail, in 90% of the cases, you fail to give these basic simple questions, which is very basic. Anybody, and it must be. These are kind of like igniting a car. If you are not going through this particular ignition, how can you roll the car? So that's why we fail in the examination most of the times, failing to answer these basic questions. We do not ask you or make you fail not answering a relationship of the second part of the duodenum. We do not fail you in examination by failing to answer the relationship of superior surface of the urinary bladder. We do not make you fail. This is what it takes to pass. This is what it takes to fail. But anyways, coming to this particular joints, whatever the joints you are seeing, the story doesn't stop ever identifying this joint. It is the beginning only. If you see this particular joint, hip joint, then you have to answer it what kind of joint it is. What kind of joint it is? So then the question asks, what are the different types of joints? And again, we going back to the basics where we start again. And again, on the basic part, we get 0 answer. So we do not know that what are the basic types like fibrous joint, synovial joint, cartilaginous joint. These are the 3 basic types of these joints. What do you mean by fibrous joint? Where you see the fibrous joint? Where you see this cartilaginous joint? What do you mean by the primary cartilage? What do you mean by the secondary cartilage? What is synovial joint? What makes this different between synovial? What is the basic elemental feature which differentiates between the cartilaginous joint with the synovial joint? It is the movement which you do not have anywhere else, which makes this particular joint as a synovial, which is lubricated, having the membrane, having the fluid, and it is versatile in nature, and it receives the blood supply. But anyways, so coming from there, so once you identify these different types of joint which you seeing here, the thing which you have to mention out here is the type of joint you are looking, whether this joint looks healthy or not. This is a normal healthy looking joint. So if by any chance, if you are seeing unhealthy thing, which is a disease thing, we should be able to identify this is something wrong, which is not normal. You may not be identifying the exact nature of this particular disease which is there, but you should be at least able to identify this is not a normal thing. That's it. And you should be looking for some detailed understanding or probing deeper. That's what is expected of you. But anyways, these are the kind of things which you are going to identify with this particular joint. Now then, this particular joint which involves here is the hip joint, which is largely affected because of the fracture of this particular neck of the femur. So to identify this particular neck of the femur, we have a kind of lines which you identify. This is a line which is indicating the lower part of the neck of the femur. This is a line which is present in the upper part of the neck of the femur. We call these particular lines as Shenton's line. There are 2 lines that you have to understand, the upper margin and lower margin of the neck of the femur. This is the lower margin of the neck of the femur, and this is the upper margin of the neck of the femur. So we get an imaginary line starting from this particular posterior iliac spine, dropping down to this particular superior border of this particular femur, and another line which is starting from this obturator foramen and going down to this particular inferior border of the neck of the femur. And if this particular lines you are seeing has B line and A line, which is not a falling in kind of continuity, we see that this is a disease. It may be fracture, it may be disability, which is arriving out here is because of the dislocation of this particular joint. So these 2 lines, and finding these 2 lines are important to identify the disease of this particular hip joint, which is involving this particular element, which is known as identifying these 2 A line and B line. We call them a Shenton's line. Shenton's line A and Shenton's line B. But anyway, these are the 2 elements that you have to identify and know here. Next joint, which is the knee joint. Again, whenever you are studying this particular joint, you have to follow this particular decorum. Like, what are the views that you have to see here? What are the region which you are seeing here with these views? What are the shadows you are seeing here? Bony shadows, soft tissue shadows. Bony shadows, soft tissue shadows. If you are looking at, narrate the bony shadows, then you have to identify these soft tissue shadows. If you are looking at them, then you have to look for this particular margin, if this margin is healthy or not. Then the joints, if you are seeing the joints over here, in this particular bone or in this particular joint or in this particular skiagram, what are the 2 different types of joint you are looking or seeing? What are the joints you are looking here at here? How many joints you are looking at, by the way? 3 joints, 2 joints? 2 joints. What are the 2 joints? All right, knee joint and, now if I say we are seeing 3 joints, how about that? So if you are saying it's 3 joint I am looking at, is 3, 2 or 1? Knee joint, 1 number, আর কিছু? আচ্ছা, আরেকটা জয়েন্ট দেখা যাচ্ছে, সেটা হচ্ছে সুপিরিয়র টিবিওফিবুলার জয়েন্ট। আচ্ছা, 2 নম্বর, আর কিছু? আচ্ছা, এখানে আরেকটা দেখ, ফ্রন্ট অফ দিস এই রিজিয়নে কি থাকে? প্যাটেলা। তার প্যাটেলো ফিমোরাল জয়েন্ট থাকবে? যদি প্যাটেলা আর ফিমোরা থাকে, প্যাটেলো ফিমোরাল জয়েন্ট হবে? হবে না? না হবে? থাকবে না থাকবে না? থাকবে। তিনটে জয়েন্ট দেখা যাচ্ছে, আর কোনো জয়েন্ট দেখা যাচ্ছে? So it's not a kind of like a joint which you are looking here, but another joint is possible, which is known as syndesmosis, which is known as the middle part of tibiofibular joint. So that's kind of joint which is there, which is a tricky way we can ask question. So in a questions like this, we can give a diagram and ask you, write the 4 joint you are looking at. Now 3, 2, 1 or maximum 1, so 50% will get the one joint which is knee joint, then rest is that. But the 4 joints we are looking at, which is not there in your mind unless until you are reading the stuff. So what mind doesn't know, eyes cannot see. Anyways, so we have to identify this particular joints, knee joints to be emphasized over here, but don't be kind of like overlooked by this particular additional joints in this particular diagram plate also projects along with this particular knee joint. Now, if we see a lateral view X-ray on this region, the location of the patella which justifies to us. So we can see this particular lateral view of the knee joint, which indicates this particular patella. So whenever you are going to see the patella in detail, we will look for this lateral view X-ray, which is lateral view of medial lateral or lateral view of this particular joint, which involves this patella very well. So we can identify this particular 4 joints as well over here, 1, 2, 3 and 4, which is also visible in this particular lateral views as well. So you have to identify the bones, we have to identify this particular joints which normally is present. Nobody asking about diseases, only thing, normal things which is visible in here will be tested in examinations. Moving to this particular joint, the last one, the inferior one, which is the ankle joint, which involves several other joints which is present in it. The views over here which you are looking at this particular joint is, which you have to comprehend here. This particular view we are seeing here, we call them as AP view, also known as superior inferior view, also known as dorsoplantar view. So this is the same view which you are looking here in this particular picture of this ankle joint and foot. This is a lateral view of the foot which you are seeing here, and this particular view of this ankle joint we call them as superior inferior view, also known as dorsoplantar. That means from the dorsal side, from the plantar region we are seeing here, and as well as this particular view is also known as the AP view. So superior inferior view, also known as dorsoplantar view, also known as anteroposterior view. Again, whenever seeing here, you have to say that what are the views you are seeing here, the region what you are seeing here, showing bony shadows, showing white tissue shadows like this, showing soft tissue shadows like this, then joints. So again, we have to follow the same thing. What are the bones you are seeing here? Have to identify this particular bony landmarks. Then you have to identify this particular region, what you are seeing here, and the joints like interphalangeal joints, metatarsophalangeal joints, and metatarsal joints, etc., etc. So all these particular bones you have to identify, especially this particular carpal bones, tarsal bones, and metatarsal bones. The metatarsal bones have got like these elements that you have to identify. The base of the metatarsal that's projected over here. This is a shaft. This is the head of this particular metatarsal. Joining with these phalanges, there are 3 phalanges are there: proximal, distal, and intermediate, depending on this particular toe you are looking at, and this particular joint which is present in between there. Distal interphalangeal joint, proximal interphalangeal joint, intermediate interphalangeal joint, or metacarpophalangeal joints or metatarsophalangeal joints, whatever the joints you are looking here, collectively we call them this particular joint metatarsal joints. Then you have to identify these bones which were present over here. So talking about the other views of this particular foot joint, this is a lateral view which is shown from the sides. Again, you have to identify the same thing, view or region, what you are seeing here, then shadows, whatever you are seeing here, bony shadows, soft tissue shadows, bony shadows, what you are seeing here, soft tissue shadows, seeing where, and this particular region, if that thing involves any kind of joint, what type of joint it is. If you are going to figure it out, what type of joint you are seeing here, where is the location of the ankle joint, where is the location of the subtalar joint, where this particular metacarpophalangeal joint, metacarpotarsal joints, these are the locations and the regions that what you have to figure out. Then if you know this particular normal thing, we can go and talk about the abnormal things later on. So basic thing about this particular foot joint is that you have to identify this individual tarsal and the metatarsal bones which is present in this particular picture, which is the skydiagram view we are seeing here. This particular skydiagram picture, we say that superior inferior view, that means this is a together superior to inferior, that is penetrating, also known as this dorsoplantar view. You are seeing from dorsal side to the plantar side of the foot, and this same thing also known as the AP view or anterior posterior view. So these things comes together, and along with that other view which is there, which we emphasize or commonly say about these lateral views in this region. Along with that, we have an oblique view as well. So we are not complicating at this point. We are just emphasizing two basic views at this particular, most of these particular undergrad classes, which is involving in our learning objective. So identifying these particular bones, which is important to us, we do not ask about the rocket side questions again and again. We identify the basic thing, identify the bones, identifying the joints, or name the joints, which is very simple and very easy thing to identify. Failing to identify those things brings us to different domains. And if you identify those things, we usually stick to that particular points. Like if you are identifying any joint, what kind of joint it is. So better know this particular joint individually whenever we are seeing here. If we are seeing this particular bones, say for example, this particular bone, calcaneum bones. So what kind of bone it is, if it's kind of regular bone, irregular shaped bone, long bone, short bone, etc., etc. So those basic morphological architecture difference or classification difference, though we are going to ask about those questions. We are not going to ask about, tell me about this particular surface, etc., etc. So this is the very thing, very figurative thing about this particular bones, that based on this, we identify the exam questions. Pathological things, it's not required, but for interest, how we are going to learn these pathological things, we are just going to demonstrate. So this is a hip joint. We have seen this particular hip joint. So this particular line matters to us. We call them as scatter lines. That particular lines identify this particular neck. As I am emphasizing on neck, why it is? The neck fracture of the femur is commonest fracture in the elderly individual. We are going to see in our everyday clinical life. So any female coming to us, trauma to this particular hip region, we're going to have this fracture. We have to identify the basic thing, fracture, nothing else. You identify this fracture as a basic MBBS student, we have to refer it to the orthopedic things, or else you have to miss it. So this is not a picture of fracture. This is what you are seeing here, dislocations of the joint. So we have to identify this joint which you are seeing here is identifications of the joint and how this particular head of the femur is fitted on it. Then you can see that this is abnormally getting out of this particular joint or not. So you have to locate the location of this joint. So this is the acetabulum and this is the acetabular cavity. Where the head is there? It is bogged up, it's moved out. So this particular thing is not in a normal position, so that it could have a fracture and it could be a dislocation. Then we have to probe more. We have to refer it to orthopedic or further investigation process. Similar to that, we have a kind of fracture that you have to identify here. This line is interrupted over here. This is kind of pretty straight. We can see this particular margin. This one interrupted. You can see this particular projected bones over here, and it looks apparently shorter than this one. So femoral neck fracture, it looks like that. How we are going to identify? We are going to trace this particular superior border and inferior border. Unless until we do not know how to identify this particular normal thing, we cannot identify this pathological thing. This is again the fracture lines, which is visible pretty much with this particular skydiagram. You have to identify the bone, which part of the bone, upper end, lower end, shaft, or whatever. So which part is fractured, you have to identify. Then refer it. That's a simple thing we are referred to here. Here, this particular bone you are seeing here, what view you are seeing here, lateral view or superior inferior view. You have to mention it. This particular view is this one. We are seeing this particular bone, this is what? We are having a fracture on the back side over there, and this particular bone which is having a fracture on this margin where you have this ligament attached on this back side. What ligament attaches to the back side? We have this tendoachilles anchored to the back side. Tendoachilles has a common point of rupturing here. We call this as a chip rupture. This particular tendoachilles snaps off, takes this particular bone along with it. We call this as a snap fracture. As this tendoachilles ruptures, takes a piece of bone away. So this is a common point where you see this tenoacle is commonly rupturing, leading to this chip bone fracture. Under surface of this particular bone commonly gets fractured if the person jumps from height. Say a person is jumping from or making a suicidal attempt, failed suicidal attempt, for example, and jumps from one-story house, breaks this particular, falls on the foot and breaks this particular joint. What you are going to look, this particular joint, we are going to look if it is a fracture or not. Then next bone, we will be looking on the top of it. What bone lies on top of this particular calcaneum is a talus. Talus bone have got different parts, body, neck, and this particular stem which is present in here, the three parts which is present. So this is how we are going to decode this particular clinical problem based on the diseases. Again, supero inferior view of the foot region. Again, what you are seeing here is this particular bones. Now again, you have to look through what are the bones you are seeing here. Phalanges, upper, middle, lower, then metatarsal and tarsal bones like this. This is having a fracture over here. This is not easily visible because this is not very well illuminated, not projected well, but we have a fracture line faint over here, which is the base of this particular fifth metatarsal. You have to understand what is base of fifth metatarsal or what is the base of metatarsal. This is the head of the metatarsal which is rounded. Base is over here. This particular base of the metatarsal is prone to have fractures because long standing walking, who happens to walk long term, like marching, like the people on uniform, the military persons, the police person, they march a long time, they have a prone to fracture of this particular metatarsal bones. So these are the things that what you are going to look for. So each and everything, if you're looking here, then it takes time. So you have to know what you are looking for, and then you have to precise the look and identify it whether it is fractured or not. So this is how we are going to identify this particular bones and this particular radiological pictures. Ankle joint, again, we are not going to ask about anything related to disease. We are going to identify simply this particular bones which you are seeing in this particular pictures, like metatarsal bones, cuneiforms, medial, intermediate and lateral, and cuboid bones, and navicular bones, talus, which part of the talus head is presented over here, cuboid bones. Then you have this particular bone which is calcaneum. Then in this medial side, medial side projected malleolus, lateral side projected lateral malleolus. Who forms this, etc., etc. These are the very simple thing we ask in examination, but majority of the times we fail to get this simple form of answers. So this is again lateral view and AP view, and this particular view of this, the hip joints. Majority of the time we see this particular skiagram taken or given is AP view, anterior posterior view or lateral view, except in the thorax. In the thorax, we take this particular AP view, we take it as posterior anterior view. Except this particular thorax, the skiagram plates which you are seeing here, like anterior posterior or posterior steer, front side view, we call them as PA view. In thorax, we call them as PA view because the purpose of doing the X-ray in the thorax region is to visualize this particular viscera, like lungs, heart, and shadows of this. If you just take the AP view, the ribs will be crowding. So we cannot take this particular viscera picture very well. So for that region, in the thorax region, we take this particular view of the X-ray, which is PA view or posterior anterior view. What do we mean by the posterior anterior view? This ray is thrown from back side, and this particular X-ray plate is placed in the front side. So the X-ray is penetrating our body from back side to front side, and the picture is captured in here. So this is the difference that you have to keep in mind, and the logic why you are taking this PA view. Now, if you want to see the ribs, if you want to see the sternum in the thorax region, what are you going to do? You have to take this AP picture, because you want to see this particular ribs picture. You have to take this particular vertebral picture, and as well as the this sternum picture and the clavicle picture. So then we take this AP view. But in majority of the cases, 99% of the cases, this view in the thorax is PA or posterior anterior, and the rest of this view P, anterior posterior view, lateral view, and oblique view. This is all.